Hey, Kristen, are you here? I don't know if you can hear me. Okay. I think if you want to give me host permission, it would be great. Then I can record it myself, maybe.
Hey, I'm sorry. I am driving and
Don't
I
worry.
am in crazy traffic. So I'm
No
logged
worries.
in, but I'm planning
No
on just
worries.
listening. What do you need me to do?
Oh,
Make you
no,
host?
no worries. I wasn't going to bug you, but if I was,
Oh, okay.
if you were able to make me host, then I was going to just record like a shorter version, but we'll just edit this later. So no problem.
Okay. Yeah, I'm so sorry. And I'm trying to
Don't worry. Thanks for joining.
yeah, no problem.
Welcome, everyone. As people start to come in, we'll just, in a couple more minutes, we'll let folks in. Welcome. See who else is coming. So just so you know, as you guys kind of come on to the meeting, welcome. This is the CSRT Student Committee meeting for the month of October. My name is Michelle Minch. I'm the chair of the committee. We'll have some of the other members coming on shortly. We'll have them introduce them. And if you could do us a favor and just in the chat box, you can your name and what school you're with and your email, that would be great. Awesome. Maybe what you're studying as well. I know we're studying different things, so. Oh, we got some. Ferris State University. Serena. We got some Guernica Academy folks. Awesome. Welcome. Here's Sadie. Welcome, Sadie. I just mentioned Sadie. Sadie's our co-chair. I just mentioned to folks to please put their names, the school they're from, and their emails in there. We'll use that as kind of a attendance and also just to get to know everyone a little bit.
Yes, welcome everyone. We're excited to have you.
Okay, welcome, Kevin. Thanks for joining. We will start out in a couple of minutes. It's just past the hour. Okay. Thank you guys for joining us tonight. I'm excited to be able to host this meeting for you all. I'll have, my name's Michelle Minch, and I'm the current chair of the CSRT Student Committee. And I will let Sadie introduce herself.
Yes, I'm Sadie. I am the current co-chair and I am currently in CSU Northridge's program. And for the Grinnell people, we're really excited for your upcoming conference next weekend.
Yeah, really excited. We're all getting ready for that. We are going to have a CSRT Student Committee booth. Sadie also goes to CSUN, so she's going to have a booth there as well. A bunch of her students from her school are going to join us. And hopefully some of you may be attending. Are any of you guys attending the annual conference coming up November 5th and 6th up in Sacramento? Minu.
Yes,
Nice.
I will be.
Oh, wonderful. Yeah, I mean, if anybody would like to put on their video, it would be great to see faces. We'd appreciate it. And maybe during the presentation, you're welcome to turn them off. That's great. But it's just nice to see folks. Hi, Alexandra. Nice to see you. Hey, Sam. So I'll go ahead and start. Let me just. Okay. Again, welcome again. My name is Michelle. I am I was studying sonography up in Northern California and just finished the program and now studying for my boards. So that's where I'm at. And I just have a couple of announcements to make. And then I'll go ahead and introduce our guest speaker for the evening. So if you guys have any questions at the beginning, just before I go into anything, I'll introduce as well. So you guys met Sadie, she's our co-chair. And then I'll let Bianca and Carrie introduce themselves. Thank you. Go ahead, Bianca.
My name is Bianca. I'm studying radiography at LACC. The historian.
Yeah, she's on our board. She helps out. She's our historian. She helps out with a lot of social media and corresponding back and forth with our main CSRT board in the California state level. And we also have Carrie DeWeese. Go ahead, Carrie. She's our secretary. I don't think we can't hear you, Carrie, but she's our secretary. Hopefully she'll be able to come on in a little
Sorry,
bit.
I'm here.
Oh, great. Okay, go ahead.
Hi. I'm Carrie DeWeese, and I'm the secretary. I'm going to CCSF, City College of San Francisco, studying diagnostic medical imaging.
Wonderful. All right. Well, just a couple of reminders. We have some upcoming events happening. The biggest one being the CSRT 83rd Annual Conference. That's happening November 5th and 6th. And that's a big deal. We haven't had an in-person conference in about 2 years. So everyone's really excited to get in person again. We have a whole lineup of guest speakers for the day. It's a day and a half long. And for students that are members, it's $100 for participation. And you have the opportunity to hear a whole lineup of speakers. And there are, let's see, I think 8 different speakers, possibly nine speakers over the course of 2 days. There's also a student bowl. I don't know if you've ever participated in a student bowl, but they're going to have that just specific for students that are coming. And anybody who's registered is welcome to participate in the student bowl. It's usually like, I think, a Kahoot or some sort of games that they play. And then they have typically awards at the end for the winning folks at the end. So they try to make it interactive and fun for the students so they can all get together. And I believe Saturday evening, they were talking about possibly doing a social event as well. So hopefully you'll have an
Quick
opportunity.
question, sorry.
Yeah.
For the student bowl, in order to participate, do you have to pay extra or is it all included in it?
I believe it's included. So with your registration, you automatically get to participate in the Student Bowl. Good question. And that's after the first day at 4:15 to 5:15. So it's just immediately after the last speakers of that day. It starts at 8 a.m. registration, and that last speakers end around 4 p.m. And then there's kind of a Student Bowl right after that. So if you do the full day, you should be out at 5:15. It's up in Sacramento at the Gurnick School Academy. They're hosting it up there. So if anybody has the opportunity to attend, that'll be great. Hopefully we'll see you there. If you have any other questions about it, you can go to the CSRT website directly, and it has a lot of information. They also have information about the hotel that they have a good rate with if you need to get a place to stay, and they also have the information of the speakers and everything about the pricing. So the other thing that's happening is the venipuncture courses. They have both Northern and Southern California venipuncture courses coming up. They also just recently added ones that correspond with the annual conference. So if you are going to be up there, you can work it out to, it's a hybrid program. So you do the online portion of it before, and then you come and you just need to meet pretty much, I think, for a couple of hours over that weekend. You can find a time to be there and do your sticks. You do your 10 sticks in person, and they use like phantoms. So they aren't actually doing the sticks on real arms, but you get your 10 venipuncture sticks. And they have one on the 5th and 6th if you're interested and you're going to be up there. And then the next one is Southern California, December 10th. So you can also, again, go to the website and get more information about what that entails and how to register. Another announcement is just continuing the National ASRT, the American Society of Radiologic Technologists, are having their applications are open for the Student Leadership Development Program. It's just a reminder, the deadline is due November 11th, so it's approaching in the next, like 3 weeks. And highly recommend that program. I'm a participant in that currently. It has been an amazing experience. It has mentorship program. It has a whole leadership academy that you learn about, that you go into your second year, and you get assigned a membership and a mentor for the full first year, which is wonderful. And you're working with professionals, and it's just a great networking opportunity. They also, they select 2 students from each state. And if you are selected, you get to attend the annual conference, and they have a House of Delegates meeting that you'll participate in. So it's a great opportunity to see the inner workings of how the ASRT runs. They make an amazing effort to integrate all the students in the program in the week up there. It's going to be in Reno next June. So they'll pay for your travel. They'll also pay for a stipend while you're there, and then all of the activities that you'll participate in. It's great. So that's a 3-year program, and I highly encourage you guys to look also online. I can put the link as well, if you would like, into the chat. And there it is. Information and how to apply about the Student to Leadership Development Program. The other update is for November, it's going to be the National Radiologic Tech Week. November 6th through 12th is the official week, and the theme for the ASRT is Aiming to Heal. And they also have a lot of different things happening that week. Maybe on campuses at your schools, you might be having different things happening in the month of November as well. But for our student committee meeting, we're planning on having it on the 28th tentatively right now, and we are going to have it be our theme also, and we're going to have some fun activities online just to get the students interacting, and also possibly play games for next month. Just wanted to let you know that's tentative on November 28th. we'll send out more information. And then last thing before I introduce our speaker is we are going to be recruiting. I'm going to be moving out of the chair position, and Sadie will move up next month. And then we'll be opening up our secretary position. So just stay tuned if anybody is interested in, we will be putting up more information about recruiting for a secretary for the student committee. So if you're interested, feel free to reach out to us prior, but if not, we'll put that information up and then we'll announce a deadline for applications. All right, are you guys, do you have any other questions? Sounds good. Well, it is an honor to introduce Kevin Clark. He's also, I'll just read his little introduction. I'll let him take it over after that. But so Kevin R. Clark, he is an associate professor. Hello, Kevin. He's an associate professor and an associate director with School of Health Professions at the University of Texas MD Anderson Cancer Center in Houston. He served as the chair and delegate for the ASRT education chapter. And excuse me one sec. There we go. For the education chapter. One sec. And an active member of the Texas and Louisiana ASRT affiliate societies, ASRT, and the Texas Society for Advancement of Health Professions. And in 2021, Dr. Clark was elevated for ASRT Fellow, and he currently serves as the Director at Large of the AEIRS Board of Directors. And in his spare time, he enjoys playing the piano, baking homemade Southern buttermilk biscuits, and watching the Houston Astros. So without further ado, please welcome Kevin R. Clark. He's going to be talking about trauma-informed care tonight. Thank you so much.
Thank you, Michelle. Let me just get set up. And in case you did not know, the Astros won last night. So World Series bound Friday night, 7:03 here in Houston. I'm deciding if I want to pay $875 for a ticket in the nosebleed section, but we shall see. We shall see. So tonight, I'm going to just briefly talk to you about trauma-informed care. I'm really passionate about this topic. When you think of patient care today in the hospital, we are seeing this paradigm shift to more of a trauma-informed approach. So in this presentation, my goal is just to give you an overview, not to overwhelm you. But this isn't, if you're a trauma-informed, that doesn't mean you have to go take a class, you have to complete a webinar, you have to get checked off on this. It is just a framework that says the care you provide is sensitive, and mainly sensitive to a patient who might have been exposed to a previous trauma. They may have been victimized. So it doesn't take any more time if you're trauma informed. It's not like we have to add another 30 minutes on to the patient visit. It's just a framework that allows you to provide sensitive practice. Just for those of you who may not be familiar with Houston, if you drive or fly into Houston, you see two sets of high rises there at the top of the image. That is downtown Houston. And then the second set closer to you is the Texas Medical Center, the TMC. It does claim to be the largest medical center in the world. I would say that there's probably 15, 20 miles between downtown and the Med Center. And of course, it only takes you a day and a half to travel between the two. But MD Anderson makes up a pretty large portion of the Med Center, and I'm pretty fortunate to be a faculty member there. We're about 23,000 employees strong, and only about 1,000 of us are faculty members. So I'm pretty honored to be there. But this is our patient tower right here, main entrance to where the patients are a lot of our clinics. Again, the patient tower. I park in this garage. and I'd take the little journey down the sidewalk, and my office is way back there in the basement. Yes, I'm in the basement of the main hospital. And then our admin building, it's just further south of the med center. What I love about this picture is it looks like it's just sitting out there in nowhere, but actually, if you're looking at this image, you're looking south. So if you head west, you run into NRG Stadium where the Houston Texans play. So it's a pretty busy place, but I love this image because it just looks like it's just sitting out there and nowhere. And this is just where all of our administration staff is housed. So for this particular presentation, no conflicts of interest to share, but if you can imagine a topic on trauma-informed care, talking about patients who may have been previously victimized, there's going to be some sensitive information. So I just want to disclose that up front for you. And then our objectives, basically, I just want to define trauma. What is trauma-informed care? One of the big components, or I shouldn't say big, one of the major components, I guess, of trauma-informed care is that as a healthcare provider, you have to realize that trauma is pervasive. It's a pervasive problem. It's pretty prevalent. So we're going to look at some statistics from the CDC that show us that prevalence. And then we'll spend most of our time talking about the guiding principles or the 6 pillars of trauma-informed care. And then what are some specific practices, trauma-informed practices? If any of you are radiation therapy students, then you are more familiar with the term sensitive practice. Many aspects of radiation therapy, and I shouldn't just say radiation therapy, many aspects of cancer care can be triggering to sexual assault victims. And so I do believe that the ASRT has already included sensitive practice as part of radiation therapy curriculum. I could be wrong. Maybe it's coming in a few years, but so you may, if you're therapy, you may be more familiar with the term sensitive practice. And then we'll just wrap up the presentation talking about some of those foundational steps an organization may need to follow if they choose to become a vicarious trauma-informed organization. So one aspect of trauma-informed care is our ability to understand as a provider, to understand that the exposure to trauma, it may affect how an individual approaches healthcare, how they seek care, how they follow up with care. And so to kind of help illustrate this one aspect of trauma-informed care, I shared this story. There were a series of murders that took place in Jeff Davis Parish, about 40 miles from where I grew up in Southwest Louisiana. But the bodies of these 8 women were found across the town of Jennings, Louisiana. They were found in swamps and canals. We're pretty close to the Gulf Coast. And their bodies, they were found in a pretty bad state of decomposition. That made it really difficult to determine the actual cause of death. It made it hard to identify who these victims were. And victim number 8, Nicole Guillory, she was 26 years of age when her body was found. And she was found dumped right off of Interstate 10, pretty busy highway, right off of Interstate 10 while the FBI was in town investigating these murders. A lot of these women, they knew each other. Some were related. Others lived together, but they shared some common traits. They grew up poor. They lived in poverty. They suffered from mental illness, and they had histories of drug abuse and sex work. But to date, these murders haven't been solved, and I probably should say that these murders occurred 2005 to 2009. So here we are in 2022, and nothing has been solved. There's a lot of theories out there in terms of who did it and why, but report after report tell the story of how police, law enforcement were called to scenes involving these women. Some type of traumatic event, some type of violent event occurred, and police had to bring these women into a hospital, to a clinic for care. My point is, if I'm a trauma-informed healthcare provider, I am no longer going to ask a patient, what is wrong with you? You can tell that when you say what's wrong with you, the word wrong portrays, a negative implication toward, the patient and not the situation. Being trauma informed, I am now going to ask patients, what has happened to you? And if you want to know more about those murders, it's a great book there on the left, written by Ethan Brown, Murder in the Bayou. And then they actually created a documentary. I think it's a 5-part series that you can purchase on Amazon Prime Video. It's really well done, but it goes into more detail about those murders. But another big aspect of trauma-informed care is our goal as providers to not re-traumatize the patient while they are under our care. And these can be small, subtle things that we do and we routinely do, and we don't give any thought as to how that action that we just did could potentially trigger a patient who's been previously victimized. If you think of a rape victim in the emergency room, the ER doctor orders some type of imaging exam. We just kind of go bouncing in the room. Hey, I'm Kevin from ultrasound. I'm going to take you down to do a quick scan on you. And we just busted in there and totally invaded her safe place. Maybe we didn't knock. Maybe we didn't ask if we could enter. We just went in, got the patient, because our main goal is to get the exam done. When we get them into the department, I've worked in many departments where we've had to shut the door and lock it to keep colleagues from walking in. Imagine if your patient had been abused physically, sexually, emotionally as a child, and then they hear the sound of that lock on that door. It could trigger them. Whether you're in imaging or therapy, we routinely touch our patients. We position, we're heavy positioners, palpating that iliac crest. What about the individual whose intimate partner has assaulted them every day? And then here we are poking, pointing, prodding. Maybe we're not explaining what we're doing. Maybe we're not asking for permission to touch. We're just, trying to position and get the exam done. We most certainly are going to re-traumatize our patient. So the Substance Abuse and Mental Health Services Administration, or SAMHSA, they give us the best definition of trauma. It's the exposure to an incident, series of events, or a set of circumstances that the individual finds physically or emotionally harmful, or it's life-threatening, and it can potentially have lasting adverse effects on their functioning, their physical, social, emotional, or their spiritual well-being. Many times that trauma is going to produce, a sense of fear, some vulnerability, some helplessness in these victims. And we use the term complex trauma to talk about those individuals who are experiencing, trauma on a prolonged basis. It's repetitive over an extended period of time. And of course, the outcome of a traumatic experience, it varies from person to person, because we're all going to respond to things differently. So we use the term resilience to kind of describe how an individual is able to adapt and overcome, even see positive growth after a traumatic experience. If you think of sexually abused children, some of them may go into adulthood, they get married, they have a family, live a happy, healthy life. Others struggle with depression. They may find it difficult to trust people, can't commit in a relationship. And then sadly, we know literature tells us that some of these children who were abused, they can turn into an abuser themselves. But we all handle and we all cope differently. And so this phenomenon you might have heard of, post-traumatic growth, it's just a theory out there that attempts to explain how some people do see that positive growth after a adverse situation, after a traumatic experience. So it's a theory that kind of helps explain why some people are more resilient than others. And I just wanted to just quickly show you this list of traumatic experiences to show you that it is a pervasive problem. It's prevalent. Sometimes, especially if you're in imaging, when we think trauma, we think of a car wreck. There's a lot more to it than just a car wreck. We're talking about physical, sexual, emotional abuse, childhood neglect. Maybe you lived with a family member who suffered from mental illness, or maybe they abused various substances. The sudden unexplained separation from a loved one, like death or abandonment, even divorce. Poverty is a big one. Poverty is really big when we talk about trauma-informed care. Racism, discrimination, oppression, and violence in the community, war or terrorism. Certainly this isn't an all-inclusive list, but my goal here is just for you to see it is a pervasive problem, more to it than just a car wreck. So as I said previously, trauma-informed care is just a framework that's going to allow you to provide care that is sensitive to your patients, and it follows the 4R approach to kind of help you remember it. The first is realize the prevalence of trauma. The second one is to recognize the signs and symptoms of trauma. That can be difficult because if you think getting a patient history, we ask them, what are your allergies? We ask them, do you have a history of high blood pressure, history of diabetes? What we haven't normalized in the United States is asking, have you been a victim of a sexual assault? Have you experienced a previous trauma? We haven't really normalized that, standardized that in terms of our history, but we really need to do that. So that second bullet, the recognize, can be difficult. The third, respond by integrating your knowledge about trauma into practice. We're going to talk about some of those sensitive practices that you can implement. And then the fourth one, resist re-traumatizing them while they are under our care. The biggest investigation when you talk about childhood abuse and neglect and how those household challenges may affect you in adulthood, your health and your well-being later on, when you become an adult, then you have to talk about the Adverse Childhood Experience Study, the ACE study. It was a collaboration between the CDC and Kaiser Permanente. Notice they had over 17,000 adults that participated in their study. They actually did 2 rounds of data collection, but with their data analysis, they found that about 61% of the adults in their study reported that they had experienced at least one adverse experience, one traumatic experience, and then nearly 1 in 6, or 17%, reported experiencing 4 or more ACEs. What I want to do real quick is just walk you through those ACE questions. My goal isn't to re-traumatize you if some of these questions may trigger you. Mainly what I want to do is for you to kind of see how some of these adverse experiences can potentially affect adulthood. So and what the instructions on the survey asked the participants to do, it just asked them, hey, give yourself a check mark if you experienced whatever the question's asking in your childhood. So it went from birth to 17 years of age. So notice, I'll just fly through these questions. Did you feel that you didn't have enough to eat, had to wear dirty clothes, or had no one to protect or take care of you? Number 2, did you lose a parent through a divorce, abandonment, death, or other reason? Number 3, did you live with anyone who was depressed, mentally ill, or attempted suicide? 4, did you live with anyone who had a problem with drinking or using drugs, including prescription drugs? Number 5, did your parents or adults in your home ever hit, punch, beat, or threaten to harm each other? Question 6, did you live with anyone who went to jail or prison? Number 7, did a parent or adult in your home ever swear at you, insult you, or put you down? 8, did a parent or adult in your home ever hit, beat, kick, or physically hurt you in any way? Number 9, did you feel that no one in your family loved you or thought you were special? And then number 10, did you experience unwanted sexual contact, fondling, or the oral, anal, vaginal intercourse or penetration? Remember, about 61% of their study, of the participants in their study, had experienced at least one of these ACEs. And then 1 in 6, 17% had 4 or more. Just to be vulnerable with you guys, I have an ACE score of 7. I didn't have the best childhood. It was very difficult. But thankfully, at the age of 7, that toxic person in my life went away. Things got much better. But if you think about what children have to deal with today, we really need an updated ACE study. I mean, think of the bullying, the cyberbullying that's taken place that could have an effect. It could be traumatic for someone. The school shootings I think about. So we really need the CDC, Kaiser Permanente, they need to get together and update and kind of include questions that are relevant for today's society. But in their study, they kind of went on and asked about different health issues, if they were experiencing any of those as an adult. And then the very last question on their survey said, do you believe that these experiences, talking about those childhood experiences, affected your health? And so what they concluded with their data analysis was that these adverse childhood experiences and their associated social determinants of health. When I say that, social determinants of health, I'm talking about things like maybe living in an under-resourced neighborhood. Maybe it's racially segregated. Maybe as a child, you moved around a lot, never really got to, never really got a stable place to make friends and things like that. Or maybe you did experience some food shortages as a child. And so that's kind of what we mean when we say those associated social determinants of health. But what they concluded were that these ACEs can affect health and well-being in adulthood. Does it necessarily mean because you experienced a traumatic experience as a child that you will deal with, issues later as an adult? It just their conclusions were it can potentially lead to some issues. And I mean, if you'll look at this graphic from the CDC, I mean, everything from mental health, maternal health, all the way to that blue at the bottom, opportunities. It can even affect going to school. Life opportunities like getting a job, making a decent income. So definitely we need an update in terms of the ACE study, but certainly these adverse childhood experiences can affect adult well-being and of course your health. There's even been more research in terms of neurobiology and how that exposure to childhood trauma can affect a lot of other things. And most interesting to me is that it can affect brain development. Exposure to chronic stress can actually cause your brain to shrink in size. And if we just do a quick anatomy lesson, if you are under chronic stress, then your body is secreting those hormones like crazy, mainly cortisol. And it's that cortisol that causes your brain to shrink in size. And cortisol is what primes your body to fight, or maybe, freeze, or maybe flee, run away. It primes your body for that instant action. And quick A&P review, the amygdala, and that's the part of the brain. It's called the brain's fear center. It teaches you to run, jump, danger, react. That is what is on fire for a patient who's been victimized, because that cortisol has just been secreted. It is pumping through the body. It is on fire. Interestingly, the amygdala is the first part of the thinking system that evolves in teenagers. And we all were teenagers at once. We know as teenagers, we are highly reactive. That's because our amygdala is on fire. The same is true with a patient who's been victimized. They are on go, they are on alert. And so as levels of cortisol rise in your body, it causes those electric signals in your hippocampus to weaken or to deteriorate. And the hippocampus is the part of the brain that focuses on your learning, your memories, your ability to control your stress. That is why when you encounter a stressful situation, if you're walking down the road and a tiger walks out in front of you, the normal response isn't, oh, large animal, stripes, must be a tiger. That's not how our bodies are wired. We are wired to either fight, flee, or maybe freeze, because that amygdala is on fire. And if when we get to the end, I have a video that I want to share of some couple little scenarios showing trauma-informed in action, and you can kind of see how some people may be really reactive after being a victim of some traumatic event, and some may not be as reactive. They might be a little more calm. We all respond to things differently. So I just want to fly through some stats from the CDC, again, to show you the prevalence of trauma, because the first aspect or the first R of trauma-informed care is to realize the prevalence. So notice about 1 in 7 children experienced abuse or neglect this past year as a child. When we talk about sexual abuse, 1 in 4 girls and 1 in 13 boys experience child sexual abuse. When we talk about community violence, maybe the shootings that we're seeing on a regular basis in public places, assaults, or maybe fights among groups, about 25,000 lives were lost to homicide in 2020. And that is a significant increase from what we saw in 2019. Elder abuse is also a form of trauma, and that includes the financial abuse where some of these people are taken advantage of. Firearm violence, there were more than 45,000 firearm-related deaths in the United States in 2020. So that's the equivalent to about 124 people dying from a firearm-related injury every day. Intimate partner violence, talking about that physical violence, sexual violence, maybe stalking, that psychological aggression from either a spouse or someone you're dating, an intimate partner. About 1 in 5 women and 1 in 7 men reported that they experienced some type of physical violence from an intimate partner. 1 in 5 women and 1 in 12 men reported that they experienced that contact sexual violence from an intimate partner. And then 10% of women and 2% of men reported that they had been stalked by an intimate partner. Rape, really, really sad here, but more than 1 in 3 women and 1 in 4 men reported that they had been violated, been assaulted sexually. And look at the cost of rape. And that's just an annual, I mean, I shouldn't even say an annual, that's a cost per victim, about 122,000. So it's definitely a public health concern that we need to address. And then the last stat I'll show you here is youth violence. Homicide, unfortunately, is the leading cause of death for non-Hispanic, Black, or African-American youth. I know I went through that really fast, but I just wanted, nobody likes to be bored with stats, but I just wanted you to see that it is a pervasive problem. And of course, that is the first R, realizing that prevalence. So we're going to kind of work our way through the remaining 3. But I mentioned at the beginning of this talk, this paradigm shift in patient care. So I want to kind of further explain that just a little bit. I teach a health policy course here at MD Anderson. And if you have to take a health policy course, or if you ever take one, you are going to learn about the cliff analogy. It's very common to kind of describe the current state of healthcare in the United States. So we have a cliff. We have people running, they're walking, they get to the edge of the cliff, they fall off, hit the ground, they're injured, they need help. We have to save their lives as a healthcare professional. And so as providers, we save their lives by what we call tertiary care, meaning we are taking care of the injured. We're taking care of the sick. It's specialized care. Let's hope that there's a hospital somewhere close that we can bring the patient to be treated. Let's hope that there's an ambulance with a full tank of gas that can take the patient to that hospital. Only when we have tertiary measures in place then we have the ability as a healthcare provider to save their lives. But providers started thinking, why are we letting people hit the ground and injure themselves? Let's build a net or a trampoline to save them from being injured. And this is equivalent to what we call secondary care. These safety programs that we put into place to try and diagnose a disease early in its course. So when people fall off the cliff, they hit the netting or the trampoline or the basket, whatever I have there, and they bounce, they bounce, they bounce. Some will still fall through and need that immediate specialized care, but others will be saved. And that's kind of the point of secondary care. Then researchers and physicians were like, why are we even letting them fall off the cliff? Let's build a fence to prevent them from falling off and injuring themselves. And that's primary care, prevention medicine. We are trying to prevent injury. We're trying to prevent disease. And so what happens is people are running, they come up to the fence. Before long, the fence just can't handle the volume of people coming for primary care. So the fence becomes weak in places, holes form, people fall through. But thankfully, that secondary care will save some of them. And then some of them will need that specialized tertiary care. This is the current state of healthcare in the United States, and it's because of issues that we're seeing with primary care, mainly just the overwhelming volume of people coming from primary care. Physicians and researchers are now asking, who should we be targeting before they get close to the fence, before they need that prevention medicine? And the answer is in the literature, and it tells us it's the ACE study. It's those social determinants of health. It's poverty. It's racism, the oppression, any of those traumatic experiences. We need to be intervening a little bit sooner, targeting those, and hopefully prevent that overwhelming volume coming for primary care. It's kind of referred to as the ACE movement, but we call it trauma-informed care. So those 6 core principles that I want to just go through and kind of give you some practices for each one of those. And I guess you could call these like the pillars, the trauma-informed care pillars. The first one is safety. We want all of our patients to feel safe while they are in our care, including someone who's been victimized. But if you think about like waiting rooms, your waiting rooms have to have enough space so that someone doesn't have to sit in close contact to a stranger, because for someone who's experienced a previous trauma, that could be triggering for them, putting them in close contact with a stranger. The outside of your facility should promote a sense of safety. So we have to have good lighting, sidewalks, our parking lots, our parking garages, because some of these victims may choose to seek care in the evening hours or maybe at night. At the beginning of this presentation, I mentioned shutting an exam room door and locking it, how that could be triggering. Just give some thought. Are there some alternatives that you can do in your department that lets your colleagues know, hey, Kevin's in that exam room with the patient. I don't need to go barging in there. But another big part of trauma-informed care is just communicating with the patient. So saying something like, hey, I have to shut the door and lock it. Is that okay? And if they say yes, then you can shut the door and lock it. If they say no, you have to honor that no. Always with trauma-informed care, you have to respect the no. But another big thing, especially if that amygdala is on fire and they are highly reactive, you have to get them to a state of calm so that they can understand you, they can listen to you. And so one thing that you'll see in the video that I'm going to show you here shortly is you're going to hear the nurse say, you are safe. You're safe here. And if that's repeated over and over, that is going to be calming to them. The second pillar is trustworthiness and transparency. This is hard for us who work in imaging because patients are in and out pretty quick. And sometimes it can be difficult to establish that trust. But if any of you are therapy students, you will see patients. A cancer patient may see you as a therapist more than they see their oncologist. So many times you can establish that rapport, develop a good relationship, and sometimes they will disclose things to you that they haven't told their physician. But with trustworthiness and transparency, I immediately think of informed consent. A lot of our procedures are invasive. We have to get a signature. And I hope you all know that a signature on a paper doesn't mean diddly squat. Informed consent means it truly has to be informed. Our skills, our patient education skills have to shine here, and we have to make sure that the patient is aware of what's about to happen to them. But with trauma-informed care, we refer to it as ongoing informed consent. Constantly check it in with the patient. Are you okay? Is everything, are you in any kind of distress? It has to be continuous throughout the procedure. So that's one way we can help build up that trust. The third one, peer support. And this kind of comes from your colleagues. It could be that, you have a coworker who was sexually assaulted previously, maybe as an adolescent, young adult. And so they could be in a position where if the patient comes in who's been sexually assaulted, they may be better prepared to provide that care. Because what happens is they can approach the patient as a peer. They know what they're experiencing. They know what it feels like. And if you approach someone as a peer, you listen better. I think of my students. I can say the same thing over and over, and they just don't get it. As soon as a classmate says the exact same thing, they're like, oh yeah, okay, that makes sense. So that peer support is helpful. When I was first working right out of school, I remember we were doing some small bowels, and if you've ever done a small bowel, there can be hours in between images. I mean, 2, 3, 4 hours in between taking your next image. And many times at this one particular facility, we would just take the patient and put them in a holding area. It was dark. It was secluded. The nurse in the department would occasionally go by and check on them. But I remember I had a colleague who said, we have to stop secluding these small bowel patients like this. And I remember it was at a staff meeting, and he had kind of disclosed to us that he was neglected as a child. Sometimes he said his parents would make him stay in a closet. And so he said, we are re-traumatizing these small bowel patients by putting them in this area where it's dark, secluded. And if they were neglected as a child, we've triggered them. And so we had to develop some policies to change that. But peer support, it's a big one. Collaboration, mutuality. You're going to see in the video where physicians, nurses, even us as RTs, we're going to work with the patient to establish the goal, to establish the outcome. And a big thing with trauma-informed care is you are always going to thank them for coming in for care. I know it was hard to make the decision to come in, but thank you so much for coming in and receiving care. You're going to see that a lot. Making sure, this fifth one here, making sure that their voice is heard, and giving them choices. At the beginning of this presentation, I mentioned the rape victim in the ER. Knock on the door, peek your head in. Hey, I'm Kevin from ultrasound. Can I come in? If they say yes, go on in. If they say no, honor the no, respect it, don't go in. You'll see in the video that the nurse will say, can I check back with you in 5 minutes? If they say yes, put a timer on your phone. And be back there in 5 minutes. And then a choice. If you work in a trauma-informed organization, then you probably already know this, but the physician is going to ask the patient, especially in the emergency room, who is allowed, who do you give permission to come in this room? Hey, lab's outside, they need to come draw some blood. Will you give us permission for them to come in? Their voice, their choice. And then the last one, cultural, historical, or gender issues. And sometimes we're like, whatever, because it's not important to us, but it may be important to a patient who's been victimized. It could just be, a female patient says, I would prefer a female technologist take these x-rays. There's no reason as a guy to be offended by that. It's not that big of a deal. Grant that accommodation. Go find a female RT. If I'm the only one in the department, I'm going to go find a female nurse, and then I'm going to ask the patient, because I'm going to let the voice be heard. Hey, here's Sally from the ER. Is it okay if she stands in here? Because I am the only tech on staff right now. So you gotta respect their wishes, their choice. With trauma-informed care. Those are the 6 pillars. And just like we have universal precautions where we treat everybody as though they have a deadly disease, we all know with COVID now, somebody sneezes and we're like, boom, back up. I hate that. I hate that about our society. Someone said the other day, the biggest lie we've ever heard the past 2 years was, oh, it's just a sinus infection. But I hate that that's what our world has come to. But we have universal precautions where we protect ourselves as a healthcare professional, but we're also protecting the patient, not to let them become more sick. But now we have universal trauma precautions where we treat every patient as though they could have potentially been a victim of a previous trauma. And the reason we say every patient is because we haven't normalized that disclosure of a sexual assault, some previous trauma. And if that sounds weird to you, you're like, that doesn't really matter. You're correct. The details of the assault or the trauma, it's not important at all. But knowing that your patient might have been raped, as a teenager, that's going to allow you to be a little more sensitive, provide those sensitive practices. And the most important thing I'll tell you all night, this little sentence there to the left of the triangle, reassurance is not the same as assessment. Reassuring your patient, hey, it's going to be okay. That's not going to do diddly squat for a patient. If we want to be recognized on the same level as nurses and physicians, we have to step up our patient care. And so we need to assess them. So reassurance is not the same as assessment. There's in imaging, I can't tell you how many times I told a patient who was a little bit stressed out, how many times I would say, hold still. It'll be over before you know it. Give me 30 seconds. Because I'm trying to reassure, I'm trying to hurry up and get the exam done. Those words that I just said, those could have been the same thing their perpetrator told them. Hold still, don't move. It'll be over shortly. I just re-traumatized them. And if I have re-traumatized them, some individuals, they may dissociate. They may kind of space out, zone out. As a provider, I need to be able to recognize that, and I can see, okay, I've re-traumatized them. They're not here. Because that's how they've been taught to deal with it, or that's how they've just handled dealing with being triggered. And so have to stop what we're doing, because we definitely don't want to add to it. Radiation therapy, they've got some training out there in terms of sensitive practice. And I took it a couple of months ago, and I took a screenshot. I just wanted to read this to you because to me, this was the most powerful thing that I learned in the course. This was a quote from a patient who was going in for a biopsy, a breast biopsy. She was having it done in mammo. And just to show you that it really doesn't matter the modality you work in. There's something in every modality that may be triggering. She said, "I was completely unprepared for the experience. I did not realize the level of vulnerability I would feel when I found out I had to lie down on a table, put my breast through a hole, and remain completely still. I was told not to move, and I knew I couldn't scream. That in itself replicates the essence of most of my sexual trauma. I was a terrified girl in my bed, unable to move or scream, and I was all alone." That is so powerful to me. And I know now how important it is that we have to step up our patient care skills because we have to be sensitive in our practice. We have to avoid re-traumatizing them. When I was in, I shouldn't say that since we're recording, at a previous conference where I presented this, I shared how at MD Anderson, some of the sonographers are providing patients who have disclosed that they had been previously raped, sexually assaulted. They are providing these mirrors during transvaginal ultrasounds because they said it is calming so that the patient can see what's actually going on. And I shared that, and I had an educator in our field come up to me afterwards and say, "Is that really happening? I could care. That is so stupid to me. I just want it to be done and over with when I go and have my exam done." And I thought, how insensitive are you? More than likely, you've never been a victim of an assault. You probably always had control over your body. And so it was just really taken back, and it just really upset me to know that we have people like that in our field, especially an educator. So I just want to wrap up going through, well, we'll go through some of these communication steps and then I'll talk about the vicarious trauma. But I just want to kind of let you test yourself. We're going to compare what we would traditionally say for these different scenarios, and we'll compare it to what we will say if we are trauma informed. So in terms of an initial assessment, we would traditionally say, "What's wrong with you? What's the problem? Why are you here again for another ultrasound?" You know, so insensitive. You already know the answer to this one because I shared it with you. What has happened to you? Can you share what happened to you? And again, showing that respect. I'm glad you decided to come in to get checked out. It takes a lot for them, especially if they were assaulted that morning. It may take them all day, maybe a couple of days to work up the nerve to come in for care. When we get that history, traditionally we get the answers from whoever accompanies the individual, and then once we get all the information, we tell them, "Hey, go take a seat in the waiting room." If we work in a trauma-informed facility, we're going to bring the patient to that treatment room, and whoever is accompanying them is going to be asked to take a seat in the waiting room. We will separate them. And once we get them in that treatment room, we're going to say, "Can you help me understand what's going on? What's happening to you?" Moving them to the treatment room, traditionally, and you know, think if you've ever been a patient, you've heard this, just put on this gown and the doctor will be with you in a minute. And how many times do you don't know how to put on the gown, or remove all your clothing? Can you imagine how that could be triggering to a patient who's been victimized? So if we're trauma informed, before we get them ready for the exam, what can I do for you right now to make you more comfortable? And actually state the patient's name, convey that warmth, respect, show that autonomy. When we're trying to, I have here style and mode of questioning, traditionally different members of the healthcare team, they kind of come in, get what they need from the history, lab comes in, gets the blood, radiology comes in, gets the chest x-ray, you know, whatever's being ordered. But with trauma informed, remember that physician is going to ask the patient first who's allowed in the room. And then if some imaging exam is ordered, an ultrasound is ordered, we are going to ask for permission before we go barging in that room. If the patient is suspected of having, pelvic inflammatory disease because of a sexually transmitted infection, traditionally that nurse is going to say, are you sleeping with more than one person? Are you having unprotected sex with many people for money? Last month, I talked to y'all about human trafficking and how these individuals don't even know that they've been trafficked. They don't know that they've been exploited. And then here we are as a provider asking these demeaning questions to them. But a trauma-informed nurse is going to say, is someone making you have sex when you don't want to? Are you being made to do sexual things with different people? What can I do for you right now to help you feel safe? During that physical exam, basically the nurse is going to tell the patient, hey, this is what the doctor's going to do. He'll be in here just shortly. But with a trauma-informed approach, remember the physician and the patient, they're going to work together to accomplish the goals. And it could be that instead of removing all of their clothing, we just need to lower one side of the shirt. Instead of getting completely naked, we can leave some clothes on. But then they're going to work together to kind of assess different parts. Are you hurting here? Touch on your shoulder. Is there any pain there? So that we are providing that sensitive care. Traditionally, the patient's told what their diagnosis is, prescriptions are given, and they're discharged. But with a trauma-informed approach, before we let them go, please help me understand what is important to you and what you need for your own health and safety right now. You can tell them, I've got plenty of resources to help you. We can put you in contact with a women's shelter. We can put you in contact with a religious organization. We can set you up in a hotel tonight so that you don't have to go back to that house. I'm sorry this is happening to you, but I'm so glad you came in for care. And I think this is my last one. When you have that individual who's accompanying the victim, traditionally they seem to be a little overpowering. They insist that they have to stay with the patient for the entire visit. But hopefully, if you're a trauma-informed organization, you work in one, you're going to have signage up around your facility that says, thank you for coming with your loved one today. Our policy is to ensure that all patients have time alone with their provider. Thank you for your cooperation. And the last little bit I want to hit on is this vicarious trauma. Healthcare providers, EMTs, social workers, we all can be exposed to the trauma of others, and it can affect us. It may make us, kind of shut down and zone out. It may make some of us to feel a little more grateful for what we have. Again, we all respond differently. But a lot of organizations are becoming trauma informed, and these are basically the 4 steps an institution should take. The first one is to build awareness about trauma-informed approach. So you're going to train your staff on what it is, kind of like what we just went through, the 4 R's, going through, making sure that they understand what it means to be a trauma-informed nurse, what it means to be a trauma-informed RT. We're going to support a culture of staff wellness. Most places now have EAP programs. EAP where and it's free. You can go in and talk with the counselor if you need to get some things off. If you need to talk, you need to vent, you need to get some things off your chest. Even at MD Anderson, I'll say that they really have taken a liberal stance on time away from work. They realize work really isn't your priority, it's your family. And so if something's going on with your family, then you're going to be distracted. So you're not going to be able to give it your all at work. So a very liberal stance on letting us take time off to take care of what's important. I really like this third one here. Hire a workforce that embodies the values of trauma-informed care. Every interview I've been on, you can count on it. They're going to ask you, where do you see yourself in 5 years? Who cares? Like that's so not important. But can you imagine in an interview if they said, Well, what strategies would you use to build resilience on your team? What techniques have you found to be effective in developing trust with your colleagues, with your patients? Those responses will let you know whether or not the candidate is trauma informed. And then the last one, we already talked about creating that safe environment. The opposite of trauma for me is safety. So many organizations are including trauma-informed care, trauma-informed approaches in their strategic plan because it's not going to happen overnight. It's going to take some work there. So to wrap up, yes, trauma is a pervasive problem, extremely common. The 4 R's there, as part of trauma-informed care, realize the prevalence of it, recognize the signs and symptoms. It's hard to do here in the United States because we haven't normalized that disclosure of an assault or even disclosure of a previous trauma. Respond with sensitive practice, and then of course resisting that re-traumatization. We have our universal trauma precautions. Someone in New York a couple of weeks ago when I presented this, they said, we're short-staffed. I just have to get patients in, get them in and out. I don't have time to be trauma-informed. That's incorrect. Trauma-informed doesn't mean I have to, it's going to, it's going to take another 5 minutes for the CT scan. All that trauma-informed means is that time that you do have with the patient, make it count, make it meaningful. You definitely don't want to rush things because any patient, if they feel like you're rushing, that's so demeaning to them, but especially someone who's been victimized. Those trauma-informed practices, sensitive care. We talked about the foundational steps to become a trauma-informed organization. And then, of course, the goal is I would like to see all RTs in the United States be trauma-informed. I just want to share these 2 videos real quick. There's just 2 scenarios of trauma-informed care. You can kind of see their this first one, you kind of see the patient's a little more relaxed. I shouldn't say relaxed. They're just not as reactive, but I kind of want you to listen to her dialogue showing trauma-informed care, and then we'll just briefly watch a little bit of the second one. And I think I shared my volume. Michelle, if I didn't, just let me know. If it'll play.
Is it okay if I come in? Okay, I'm gonna check back with you in about 5 minutes. Can I get you something? Okay, all right, I'll check back with you. It's been about 5 minutes and I promised I'd check on you to see how you're doing. Is it okay if I come in? I'm gonna close the door so we have some privacy. My name is Jen, I'm one of the nurses here. They called me to see if there's anything that I can do to help you, and I have a long list of things that I can do to help you. But first, before we do that, I want to make sure that you're okay and that we don't have anything that needs to be addressed by the doctor. So I want you to help me out here for a second. I want you to take your hands and I want you to put them on your head and just give a feel on your head and tell me if anything hurts on your head. Is there any spots that hurt? Okay, I'm gonna take a quick look. I'm gonna have you take your fingers and kind of move your hair a little bit so I can see that area. Looks like you have a little spot with some bruising there, and we'll have the doctor take a look at that. Next thing I'd like for you to do is just give a touch to your neck and see if that hurts at all. Does that feel okay? Okay. Check your shoulders and see if they feel okay. And your arms. Just give a pat down. And then how about your chest? If you push on your chest, does that hurt? How about your back? If you push on your back, does it hurt? Okay, how about your hips? Do they hurt? How about your legs? Do those hurt? Just give a pat down your legs. Okay. Can you move your arms and legs okay? All your joints feel all right? All right. You're safe now? You're safe here, okay? I'm gonna go ahead and talk with the doctor and see about getting your head looked at and maybe even get a head CT. Do you know if you lost consciousness at all? You're not sure, or Or no, you didn't? No, you didn't? Okay. We'll have the doctor take a look at you and see if there's any tests that need to be ordered. Would you like something for pain? Okay, all right. We got you here. You're safe. And if you need anything else, you just let us know. I've got a call light right next to you. You're safe here. Okay. We'll be right with you, and I'll go grab some pain medicine.
So that's Jennifer. If you were here last month, I told you I'm working with the nurse on coming up with some grounding techniques for our different modalities in imaging and therapy that we can use to get our patients back to a state of calm, so that they can understand us. That's Jennifer. She's working with me on that, and phenomenal lady, a nurse from Missouri. We won't watch all of this one. I just want you to see Jennifer's response to a sexual assault patient who's a little more reactive.
Is it okay if I come in?
Yeah.
My name is Jen. I'm one of the nurses here. They called me to see if there's anything that I can do to help you, and I actually have a long list to go over with you.
Okay.
But before I get started on that list for you, what I wanted to hear from you are what are you most worried about right now?
He took my things. He took my purse and he raped me. And my license was in my bag. He knows where I live.
Okay.
He has my license. He's gonna come back.
Okay.
Every time I close my eyes, I see him.
Okay.
And he's gonna come back.
Here's what I want you to do. I'm going to turn the TV on behind me. And anytime you see his face in your mind, I want you to look at the TV and concentrate on what that looks like. I want you to take that information in and have that just kind of like push away any of those images of him. So it'll give you something to focus on, okay? All right.
Okay.
All right, so we've got our TV on. There's no sound because I feel like we need to have a conversation here, but anytime you need to, you look at that TV and it'll be there for you, okay?
Okay.
And I think Ellen's on, so that'll be fantastic, okay? All right.
Okay.
You're safe with me. I'm gonna make sure that all of your needs are met, okay?
Thank you.
All right, so I know you're worried about the fact that he knows where you live.
Yes.
There are all kinds of things that we can do to help you with that. Number one, letting law enforcement know to see if we can get your items back. Maybe putting a trace on some of your credit cards and things like that that are in your purse. So letting law enforcement know and start their investigation. If you're worried about like where you live, we have Metropolitan Organization to Counter Sexual Assault that can help you relocate. And you don't have to go back to that apartment tonight.
Thank you.
Okay? You do not have to go. We'll make arrangements for you to go to a hotel or something along those lines, or to a friend's house.
So anyway, I just wanted you to kind of get a sense of how it kind of plays out. And then the last thing I'll just show before I take any questions is if you go to the CDC's website, they have this graphic if you want to print out, hang up in your department. But these are just the 6 guiding principles of trauma-informed care. But you can print that from their website. The thing with trauma-informed care is that sensitive practice is just so important. And I'm really proud of the work that Jennifer and I are going to be able to put out, because it hasn't been really hit on in our field. And so I'm really hoping this does step up the care that we provide to patients. And so that, in the end, when people think of healthcare, they don't just think of physicians and nurses, but they also think of RTs. Because I don't know if I mentioned this last month, but the one terminology that I hate to hear is allied health. I am not an ally to healthcare. As an RT, I am healthcare. You need my services to make a diagnosis. So do not call me allied health. I get on a soapbox and I get mad. At one point we were going to start a track at MD Anderson in allied health, and I was like, nope. Not going to happen. Not while I'm here. I am not an ally to health. I am healthcare. So I'm really hoping that this is one of the things that kind of propels us into more of a level of professionalism. I'll take any questions that you may have. I was gonna kind of just if I have time, Michelle, a little bit more in terms of things in our field that could be triggering. And this came from the therapy program, the cancer care that I went to. It says latex gloves could resemble condoms. Cylinders that we insert into the vagina for brachytherapy, it could resemble sex toys or foreign objects that was used during their abuse. It even went to mention that an oncologist's tie that he was wearing one day triggered a patient because the tie was very similar to the man who had assaulted her. The feeling of ultrasound gel on the skin could be triggering to a patient. I was trying to see. And then this last one here, submissive positioning. When the patient is lying in a position somehow lower than or more vulnerable, exposed than the treating provider. So that's why we always like to kind of kneel down. You saw Jennifer kneel next to the patient, not standing over them. It's just, it's really good stuff that really helps step up our care. But if y'all have any questions, I'm more than happy to attempt to answer. I'm not an expert on this by no means, but it's something that we really need to further address in our field.
Hi, this is Catherine. I just want to say that that was such an amazing presentation. Thank you.
Oh, I appreciate that.
I had heard about trauma-informed care from a friend of mine who's a nanny and dealing with parents and children and stuff in difficult situations. And so I kind of had an idea of what to expect going into this, but there's so many layers to this that one cannot understand or think about if you haven't been in the situation. And, you know, I probably have a score that's more than 4, but I still wouldn't have been able to say that a latex glove could be triggering to somebody, but I can totally see how it would. Thank you so much for that. My only question is, can I get a copy of your PowerPoint? Because there were details in there that I would love to go over again.
Yeah, if you I can send it to Michelle and then she can disperse it or however works best. But when you said that, it reminded me, I didn't mention this, but many K-12 schools are going to a trauma-informed approach. So this isn't just care in a hospital. This is this is an awareness where educators are being trained to be able to respond. So this is really big. And if you go back to your programs with your professors, if any of them are going to ASRT, it's a conference that's in Vegas every year in February for educators in our field. 2 of my former graduate students are presenting on trauma-informed practices, because what they're sharing is, how many times in imaging do we hang up a shattered tib fib? You know, it's shattered in a million pieces, and how do we not know a student in our classroom wasn't in a horrible car accident years ago, and then here we are trying to get a shock factor, and we just re-traumatized, you know, a student in our classroom. And so I'm really excited to see them share some stuff specific to the classroom. Right now, my focus is just healthcare, trying to help us amp up our care, but I'm really excited to next February to go to Vegas and see my former students present on this, because as you said, there is so many layers to this.
You know, one of the things that this makes me think about is that in some Facebook groups I'm in, you know, we get into Facebook groups for very specific topics. And sometimes somebody's post at the top will say trigger warning, blah, blah, blah. And that's what this is, isn't it? It's awareness of triggers and how they can be pervasive in all parts of one's life.
Yes.
It's amazing.
Indeed. Good stuff.
That is great. Thank you so much. And I wonder, at MD Anderson, have you already started incorporating this into some of the training in the different departments, or how are you guys currently approaching it?
Yes, and what I will tell you is this training that I'm talking about in terms of sensitive practice, that's what they call it in therapy, sensitive practice. Cedar-Sinai Is that what it's called in New York? Not in California, on the other side, New York. The leading researcher got a grant through the NIH to develop this training. And it's like 6 or 7 modules you go through. And so when I presented this to New York, a therapist came up to me and she said, we call it sensitive practice in our field. And I said, okay, good to know. And so she shared with me that a colleague started this program, got this $1 million grant to develop this training. And like I said, I can't say enough about it, how wonderful it was, how eye-opening it was, especially the testimonies from these. And I keep saying women, I keep saying she, but a guy could also be a victim. But when that lady talked about the breast biopsy, I mean, yeah, we know that the breast is a sensitive part of the body, but like how that biopsy was triggering, I thought in all of our modalities, there is something that we could, work to be a little bit more sensitive about. But this is what kind of started with therapy in terms of cancer care, because interesting in this, are there any therapy students in the group? Because when you go for radiation therapy, they put those masks over you, and what it does is it holds you still so that the beam doesn't, miss the tumor or whatever and hit healthy tissue. So they put these masks over them that restrain them. And they were like, that is so triggering to someone who's been held down, told they couldn't move. And so in my thoughts, I was thinking of how, especially sonography, mammo, x-ray, how our different modalities could be triggering. But in the back of my mind, and here I am at MD Anderson, a cancer institution, and I thought, well, therapy probably isn't as triggering. It is every aspect of cancer care has something that could remind a patient of their victimization. And so I think really we just need to get the word out. I gave this presentation for an ASRT webinar back in March. And I can't tell you how many people reached out to me afterwards, and they were like, thank you for being vulnerable. Because disclosing your A score isn't something you're really proud of. I think I've been resilient, but I can't tell you how many people reached out to me after that webinar. And I think they told me I had about 1,500 people on the call, but reached out and they were like, thank you for doing this, because I'm an RT. I was assaulted years ago, and it's like my voice has never been heard. And so I hope it's making a difference, but we still have a long way to go. But in terms of cancer care, nearly every aspect of cancer care can be a trigger for a patient. And I don't mind sharing that link to the sensitive practice. Any healthcare provider can sign up. You go through, and basically they want to know, will you ever interact with a cancer patient? And so if you say yes to that question, you can go through and complete the modules. I did tell them in one of their modules, they had the word technician in their presentation, talking about the mammo technician. And I was like, that could be demeaning to us who are technologists. That could be very demeaning. So you may want to fix that. But I can share that link with you. And like I said, it was so eye-opening for me. That's where I learned about the latex glove, the tie. They even talked about, one oncologist said he was kind of caught off guard because the patient asked him to leave. The nurse came in to see what was wrong, and the patient said, his voice sounds just like the guy who raped me. And I mean, you can't control those things. There's no reason for us to get upset over it. But in this particular class, they give you some things. They provide those scenarios that you can kind of work through. What's the best way to respond? So I can share that with Michelle, and she can send that out to y'all as well.
That would be great. Do you think that'd be something we could just post on YouTube as a link in the detailed description? Then people can have access to it there. That's a great resource. Thank you so much.
You bet.
Well, thank you. I know it's getting late out where you are.
It's
Texas.
bedtime.
So we really appreciate your time.
You bet.
For being available for both months. Thank you so much. It's been amazing.
Thank you. It was really good.
Thank you.
Really
Appreciate it.
informative.
And thank you all for joining us tonight. Please, we're going to be posting on YouTube for folks who weren't able to participate. If you know anyone, please feel free to share maybe in the next. So we'll get it up there, and you can refer back and hopefully spread the news of getting folks informed about trauma-informed care. Thank you so much.
I did
for
have
participating.
sorry.
Yeah, please.
I
go
did
ahead.
have one question. When is like, do you guys have like a calendar of when you do like the Zoom meetings and for the students? And because I found this obviously on the CSRT website, because I signed
Yes,
up for something else.
perfect. So we'll try right now. The dates. The committee's going to come together and probably put together.
Is it just me or is she freezing?
She's freezing.
She's freezing on
Okay.
my end too.
Michelle, you're freezing. We're not hearing what you're saying. Thank you, Kevin, so much. I have to go. I really, really appreciate this. I hope to be able to pursue it more. I'll be right there, baby.
I appreciate it. Have a good evening.
Coming.
To answer your question, Traceon, is that how you say it? That's pretty.
Yes.
Yes. I don't know if Michelle's going to chime in. Michelle, are you there?
Oh, hi. Yeah, I just got reconnected. Sorry, guys. I'm not sure how much you heard. I said, yeah, currently we don't have a list of dates, but the committee's to get together and hopefully we can work to post the CSRT. We don't have a separate site to post the dates, but we could look at as soon as the group comes together for the new year, November 28th, and then in January through next June, they should talk about which dates. It's typically we're doing the fourth Monday of the month.
Oh, okay, perfect. And then will you guys like just put them also like I like the Facebook page. So would that be like a good spot to kind of look out for things too?
Yeah, we've been doing Instagram posts pretty
Okay.
regularly. Yeah, Instagram, we've been and Facebook as well, but I'd say Instagram more than anything at the moment, just for putting all of the events.
Okay, perfect. I will definitely like the Instagram then too.
Awesome. Yeah, thank you so much. And thanks for tonight.
Thank
We
you.
appreciate it.
Yeah, no, thank you. It was very, very informative. So yeah, I really appreciate it.
Okay, everybody. Have a great rest of your Monday night. Take care. Thanks,
You as
Kevin.
well.
Thank you, Kevin.
Thank you.
Bye-bye.
Good night. Thanks, Kevin.
Bye.
What did you bring that in?